it's incumbent on us as nurses to stay informed about these newly approved drugs or new indications in drugs, because we're the front line in helping these patients manage adverse events. Many of these drugs are designed so patients have to stay on them for extended periods of time, or at least they get the greatest benefit by staying on extended periods of time. So our patient education is key in helping patients do that.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS. And today we're talking with Teresa Knoop, nurse consultant in Nashville, Tennessee, about the latest updates and approvals in oncology pharmacology. You can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Teresa.
Thanks, Jamie. I'd also like to welcome the listeners and thank ONS for giving me the opportunity to participate in this podcast.
To start things off today, can you briefly describe the difference between approvals and accelerated approvals for the drugs that we see in oncology?
As Americans, we really benefit, I believe, from having access to probably the safest and most advanced pharmaceutical system in the world. We have a consumer watchdog group, and that is through our Food and Drug Administration, which we'll refer to from here on in as FDA. And it's the Center for Drug Evaluation and Research, also known as CDER. And that group really ensures that the drugs that become fully FDA approved or through accelerated approval have undergone extensive testing. So what's the difference in the two? Well, full approval through CDER and the FDA means that those drugs have gone through their laboratory testing, human clinical trial testing, very extensive clinical trials to make sure that they are effective and that the benefits of those drugs outweigh the risk. CDER, which is a team of physicians, statisticians, chemists, pharmacologists, and other scientists, do independent and unbiased reviews of the data that's presented to them by a drug company. And the drug company, as I said, has conducted extensive both laboratory, scientific, and human clinical trials. And the final approvals are based generally on measurable clinical and biologic findings and are known as endpoints. And these endpoints for full approval are typically endpoints like overall survival or progression-free survival. Well, for those full approvals, these usually require long follow-up periods. So you might imagine from a drug going from the basic science setting, from the laboratory setting through clinical trials, through follow-up for overall survival can take a long period of time. When an FDA final approval is done, we rest assured that that's been reviewed thoroughly by CDER. That process is within a very structured framework that looks at analysis of the target condition or type of cancer. What are the available treatments? What are the benefits? What are the risks from all the data presented by the pharmaceutical company? And finally, do we need to take any special strategies for managing those risks? Well, as I said, it takes a long period of time. In 1992, CDER established a new program that would help these drugs get expedited, particularly in life-threatening or serious diseases like cancer. So they established an accelerated approval pathway for these promising therapies. They were hoping to shorten that period of time And a number of our cancer-fighting drugs have come onto the market through this accelerated approval pathway. And in fact, the next time you look at a new drug that's approved, take a minute to look at that package insert, and it will tell you if it's approved through the accelerated approval pathway. They're very clear on that. So what's the difference in that full pathway? Well, accelerated approval pathway approach, it allows CDER to approve a drug that is demonstrating what is called a surrogate endpoint that is reasonably likely to predict a clinical benefit, or on a clinical endpoint that occurs earlier than, for example, if we waited for overall survival. So it may not be as robust as that standard endpoint of overall survival, but it is promising in looking like it's going to reach that endpoint. So a surrogate endpoint is kind of like a marker, like a lab measurement, a radiographic image, physical sign, or other kind of method or measure that predicts clinical benefit, but is not in and of itself a measure of that benefit. So by using surrogate endpoints, the FDA realized that they can look at the data that's brought from the pharmaceutical company and look at the predictions of that data and shorten that amount of time that is required before the drug receives a full FDA approval. This pathway is really useful when these drugs are, as I said earlier, treat diseases that are life-threatening or very serious and whose disease course might be long, and that extended period of time is needed to do a full measure of the full effect. Now, what we need to know about these accelerated approvals is as the drug enters the market, that drug maker, that pharmaceutical company is required to conduct what are called post-marketing clinical trials. They have to go ahead and verify and describe those typical endpoints. It's just the drug can get to market before those are reached. Now, there's not a worry about that because they're watching those trials very, very methodically. They wait for those trials come in, and they are called confirmatory trials. So if the confirmatory trial comes back to the FDA and the drug actually proves that, yes, that promise we saw in that drug, that surrogate endpoint that we saw actually fulfilled that endpoint that we would have reached for full approval. When that happens, the FDA will then go back and grant that traditional or full approval for the drug. Now, if the confirmatory trial doesn't show that the drug provides clinical benefit or has a greater risk than thought prior, then the FDA has procedures in place that could lead to removing the drug from market. It can help us kind of rest assured that we're getting these drugs to market in a more expeditious manner, but yet we're still conducting those trials and we're still getting to those endpoints. And there are a lot of websites that are dedicated to new drug approvals, what drug got a new indication, but they also will show you a list of all of the drugs that have gotten approval for cancer through accelerated approvals. They will also have a list where they've moved on, those drugs then have moved on after confirmatory trials to show that they've been verified for traditional approval. And then they even have a list of the drugs in which the confirmatory trials did not hold up to the scrutiny or to the data. And those are the drugs withdrawn. So I know, Jaime, you have mentioned that the episodes will contain information about these different websites. I believe Jaime is going to put all of this information on, and I've listed these different websites through the FDA in their quest to remain transparent with us about all of these drugs.
Thank you so much for that very thorough explanation. I think for our nurses, as we are trying to drink from this fire hose of new drug approvals, your explanation of how the accelerated pathway has allowed things to come through quicker than maybe what we previously were used to, that helps kind of reconcile those two realities. I think it's also important, the information you shared is we need to be able to explain that to our patients. Some of our very savvy patients will find the package insert and they'll find information online. And so for them to see it described as an accelerated approval, it's important for us as nurses to be able to provide them with that information and that reassurance that the data is still coming in. They had enough to feel relatively reassured that it will provide the benefit that they have seen thus far, but those evaluations continue. And then, as you said, sometimes it turns out they do have to kind of backpedal or pull that from market, though in my experience, it doesn't seem like that has happened especially often, but that mechanism is there, again, to ensure safety and continual oversight. So thanks for providing that great explanation for our nurses to be able to, help educate our patients as well.
You're welcome. And you summed that up very well, Jane.
Let's look back to this past year. We're in a new year, but, what are the new notable cancer treatments or agents that were approved by the FDA back in 2022?
We actually had another very good year, maybe a few less approved this year than in past years. I've been doing this kind of work with these new drugs for several years, and sometimes we'll hit above the 20 new in a year. But this year, we actually have 15 new drugs approved for cancer treatment. And please note, these are cancer treatment drugs, not supportive care or other types of drugs. So it was a good year for new approvals. And when I say new approvals, I do want to make sure that everyone understands these are drugs that have been used only in the clinical trial setting, and they have now received either accelerated or full approval by the FDA to be used commercially. So out of those 15 new drugs this year, 10 were for solid tumors, 5 for hematologic malignancies. 12 of the 15 were either molecularly targeted or immunotherapy agents. So still, that's kind of the majority of what is coming through. 1 was a cellular therapy, 1 a radiotherapy agent, and 1 what we call a first-in-class adenoviral gene therapy. So an exciting year. Of note in 2022, there were actually 2 of those 15 were new biosimilar monoclonal antibodies. Just to remind everyone, a biosimilar is a biologic product, a biologically made drug that is based on a previously approved FDA drug called the reference product or the originator product. These are typically right now what we have seen are monoclonal antibodies in cancer treatment. So we know that monoclonal antibodies are developed biologically. Why we don't call these generic drugs like we do maybe if it was a small molecule is because generic drugs are created chemically. These drugs, hence the name biosimilar, are created biologically to be as similar as possible to that reference drug. They have to have the same safety profile, the same efficacy as that reference drug or that originator product. So this year, we have seen 2 new biosimilars to the reference drug, bevacizumab. Now, bevacizumab is a drug that's been around, I think, since 2004 for a long, long time. But what these 2 new biosimilars do is they are made biologically as similar as possible to bevacizumab, but they give our patients more cost-effective treatment options. So these drugs are more cost-effective to develop than that originator drug. So our patients' copays, hopefully, will be lower if these biosimilars are used. So for these 2 particular biosimilars, or biosimilars to bevacizumab, our patients have now received more cost-effective options for types of cancer like non-small cell lung cancer, colorectal cancer, ovarian, cervical, renal cell, and glioblastoma. So a lot of our patient population. We also have seen 4 new small molecule drugs. And these are small molecule. These are more of those chemically made drugs that are not biologic products, but chemically made, and they target many different pathways. Tyrosine kinase pathways, IDH and RAS pathways are some of the ones that we've seen this year. Those 4 new small molecule drugs are pacritinib, futibatinib, olutasidenib, and adagrasib. That was a mouthful to say all of those. The one thing, and if you've ever heard me do a presentation, the one thing I always do is try to get you to think more globally about these drugs. So small molecules in my mind, typically they're non-proprietary names end in IB. So all of those end in IB. So you're already thinking, wow, okay, small molecule oral agents probably have drug-drug or drug-food interactions. And I need to do a lot of patient education because these patients are taking these at home. So that's kind of the 4 new small molecule drugs that were approved. We also had new monoclonal antibodies approved. There was one that targets the immune system particularly. That's tremelimumab. And there are other pathways that we've seen that are targeted by these monoclonals. There's one monoclonal antibody this year that combines 2 drugs into one IV formulation. So they've taken nivolumab, which if you've given any immunotherapy drugs at all in the last few years, you're probably very familiar with that drug. It's used in many disease indications, but nivolumab and a new monoclonal called relatlimab. So relatlimab and nivolumab have been combined, 2 drugs into one IV formulation. So it's like, again, hitting kind of 2 different targets in the immune system. There also is a classic antibody drug conjugate that was approved this year. That's called mirvetuximab soravtansine. That one, actually, when you think of an antibody drug conjugate, that's a monoclonal antibody that's going to that target, but it's carrying along a payload. And in this case, it's a payload of cytotoxic chemotherapies delivering right to that cancer cell. There was a new cellular therapy developed this year, cellular therapies. You may know them more as immune effector cell therapies. There's several names, living cell therapies. These are therapies in which agents are made from the patient's own T cells. So the patient's own T cells are taken out. They're genetically engineered to target the patient's own cancer. So they take those T cells, genetically engineer them, give them back to the patient, and they go and target the patient's own cancer. This particular one, ciltacabtagene autoleucel, is for multiple myeloma, and it's known as, most of these are right now, there are subclasses of cellular therapies. This one and the ones that are currently FDA approved are known as CAR T cell therapies, chimeric antigen T cell receptor therapies. Again, taking the patient's own T cells, engineering them to give back and target their cancer. Very exciting, and particularly exciting for our patients with multiple myeloma, because this is for patients who've received heavy pretreatment with already FDA approved drugs, and it gives them another treatment option. An exciting development we're seeing, in fact, there were 3 new drugs in 2022, is the area of bispecific immunomodulatory drugs. We talked about monoclonal drug conjugates, or 2 monoclonals put into one formulation. This is a little bit different in that it is one drug, one monoclonal antibody, but it's bispecific, meaning it can attach in 2 different areas. So these drugs can either be formulated as what we know as fusion proteins or monoclonal antibodies. So they're not all monoclonal antibodies. There are fusion proteins. The promise in these lies in one drug that is targeting 2 different areas. For one, it targets antigens actually on the tumor. So it's doing that direct targeting to that antigen on the tumor. But the other arm of the monoclonal antibody is engaging T cells. And when you engage T cells and draw them to the tumor, you stimulate that immune response. And it's really kind of a double whammy approach to treatment, these bispecific immunomodulatory drugs. As I said, there were 3 this year. Tebinifus, TEBN. Listen to what I just said. That wasn't a MAB at the end. It was a FUSP, and that's a fusion protein. And teclistamab, which ends in MAB, so we know it's a monoclonal antibody. And mosunetuzumab, again, another monoclonal antibody. So bispecific immunomodulatory drugs are very exciting novel treatment. Another very novel development is the first-in-class adenoviral vector-based gene therapy. This drug is nadofaragene furanovic. Again, it's trying to tell you what it is. Adenoviral vector furanovic. It has gene in the first name. So these generic or non-proprietary names really try hard to let us know what the drug is. But this is given intravesically for non-muscle invasive bladder cancer. So this drug is a non-replicating adenoviral vector-based gene therapy. It delivers a copy of a gene that encodes human interferon alpha 2b to the bladder urothelium. And that results in cell transduction and local expression of that interferon alpha 2b protein that then has that anti-tumor effect. And finally, in 2022, we saw a radiotherapy agent called lutetium Lu-177, vipivatide tetraxetan. That is one of our new radio-labeled therapy agents. It's given to patients. This one, in fact, is for prostate cancer, but these are usually given in approved centers because you have to have the shielding and the specific rooms to be able to give those types of drugs. So that's what 2022 brought us, Jaime.
So let's just take a pause for a second and congratulate you for being able to say all of those drug names. I joke, but it is a challenge. We certainly want all of our nurses to know the names by their generic or their biosimilar, that non-proprietary name, because it is important. But when they make them so challenging to pronounce, it's almost like I can't even get through this word. So thank you for giving us the pronunciations. I will say that I frequently have to go to, usually it's like the NCI's website, and they have a little speaker you can push to pronounce the name for you, because some of them I'm like, I have no idea where to even start with this name. So thank you for that great overview. It's just overwhelming to me. It makes me proud of oncology nurses. Like, look at what just happened in a year's time. Just new drugs that if we work in a generalist practice and treat all different types of cancer, we might be seeing all of these drugs at some point in our care. And so what other nursing specialty is seeing things change so rapidly that we have to keep all of these impossible to pronounce names on the tip of our tongue, different drug classes, different targets, different cell pathways? It makes me proud to be in a specialty where, we are called to and expected to continue our learning at such a rapid pace, because that's what our patients need, because that's how fast the science is moving. So, that's what makes oncology so interesting and unique, is every day and every month and every year is different because care is changing. So as we look back again to 2022, can you summarize the FDA approved treatments that perhaps were already approved but received new indications?
2022 actually brought some really significant developments in regard to prior approved FDA drugs receiving new indications. So the drugs we just went over, as I said, for the last few moments, were those drugs that have been in clinical trials and got their first approval. However, what we have to remember is when a drug gets an FDA approval, whether it be accelerated or final, then clinical trials are going on. Typically, they get approved for 1, possibly 2 indications on that first approval. But there are clinical trials ongoing in other diseases and other indications. So we will then see drugs after those clinical trials are conducted. That's taken to CDER for approval for that new indication. So there was a lot of activity. There were about 23 drugs that gained a total of 26 new disease indications in 2022. So another really good year. When I say a good year, it just makes me feel so good to know that the end result of all of this is that our patients have more treatment options available to them and more than they ever have before, which is just a wonderful thing. So to start, let's talk about tumor agnostic drugs. We see a continuation in indications for tumor agnostic drugs. So what in the world does that mean? Well, these are drugs that are prescribed for particular biomarkers and not necessarily tumor histology. You have to really stop and think about that. That is an entire paradigm shift in how we treat cancer. We always want to know the histology. What type of cancer are we dealing with? But as important as that is, we have to know what biomarkers we're dealing with. And are these pathologic variant biomarkers? Are these actionable? Do we have drugs that can treat the biomarkers in cancers? What these drugs are called are tumor agnostic. You might have a BRAF V600E mutation. It doesn't matter what your histology is. If you have that particular variant, then that drug can be given because that's a pathologic variant that is what we call actionable. It's actionable because we have a drug that targets that. So you might have a lung cancer or a breast cancer or a colon cancer, but if you share that same mutation, if you have that particular mutation that this drug treats, this drug would be given. So there were actually 3 of these that got new indications this year. Alpelisib, which is got an indication for PIK3CA related overgrowth syndrome. There are 2 drugs in combination, dabrafenib and trametinib, that target BRAF V600E mutations. And there's a drug called selpercatinib that treats RET gene fusions. So if you had a RET gene fusion, it really wouldn't matter what your histology is. If your profiling, your biomarker profiling came back and showed you had a RET gene fusion, this is a drug option for you. So all of these were new indications for older drugs. But the more of these drugs we have, the greater we shift that paradigm to treating biomarkers instead of just histology. This is why so many of our patients are getting biomarker testing, either at diagnosis or upon recurrence. The exciting thing for our patients is these often will be used to treat more advanced cancers in which you discover a biomarker and can give patients potential treatment options when other options may have been exhausted. So it gives many of our patients who kind of were at the end of the line as far as potential options to treat their histology. But if you find these particular biomarkers, they could have another treatment option. We also saw the approval of the first drug approved for HER2 mutated non-small cell lung cancer. We know that non-small cell lung cancer is one of those cancers that is very, very biomarker driven in how we treat it. But we haven't had a drug for HER2 mutated non-small cell lung cancer. We do now. It's called trastuzumab deruxtecan. Again, I'm going to point out trastuzumab, we know, NCPD, so we know it's a monoclonal antibody. Deruxtecan is a cytotoxic agent. So this is one of those antibody drug conjugates that you're giving. It's doing the monoclonal antibody thing by attaching to the HER2, but it's also taking in that payload of chemotherapy, cytotoxic chemotherapy. HER2 joins a long list of biomarkers that are tested in non-small cell now. EGFR, ALK, KRAS, BRAF, NTRK, RET, ROS1, MET, PD-L1, just showing how extensively biomarkers play a role in treatment of lung cancer. Another really notable approval for a new indication for that very same drug. So trastuzumab deruxtecan also got an incredibly important new indication this year. And this is for adult patients with unresectable or metastatic HER2 low breast cancer. And these are patients who have either received chemotherapy in a metastatic setting or they have developed a disease recurrent during or within 6 months of completing their adjuvant chemotherapy. Now, what's important about this? Let's focus on the fact that these women are in a category called HER2 low. These are IHC1 plus or IHC2 plus, ISH negative. And what this means is we have always kind of said, oh, you're either HER2 positive or you're HER2 negatives. And if you were HER2 low, you were grouped in the HER2 negative group of patients for whom we did not think these anti-HER2 monoclonal antibodies or drugs would work. The data from this trial has shown effectiveness in that HER2 low group of women with breast cancer. So this has opened up an entirely new treatment option for women with HER2 low metastatic or recurrent breast cancer. And it is the first time a HER2 targeting agent has shown promise in this particular population of patients, which is huge to that subgroup of women.
And in addition to that, have we seen any other notable progress for cancer therapies in terms of histology?
Well, we have looked at this year, if you looked at all of the approved drugs or new indications, I counted in 2022, there were 26 different cancer histologies that gained newly approved drugs or new indications of formerly approved drugs. And that's not even to count the tumor agnostic population that based on their biomarkers might have new drug options. So that progress alone has affected a multitude of our patients. Another new project that I just want to point out that was created recently by the FDA is something called Project Renewal. And this is a public health initiative established by the FDA Oncology Center of Excellence. And what it's doing is it is updating labeling information for all of our oncology products. So, as we mentioned, these drugs will get accelerated approvals or final approvals, but then the story continues. The story goes on. Clinical trials will either confirm the data or not confirm the data. We also get new information that comes up in our post-marketing setting, and that might support changes in those product inserts that we so rely upon. This Project Renewal is going back and making sure that every oncology product on the market today has labeling that's updated, contains all the information about post-marketing settings, and is really working to address this challenge of outdated product labeling. This is how we reduce that potential risk to our patients by making sure all of us who are working healthcare with oncology patients has updated evidence to use these products safely and effectively. And I did want to point out, I think that's a huge amount of notable progress for 2022.
Absolutely. I definitely agree. And I think the last thing you mentioned of just that Project Renewal and updating those package insert drug labels, I think that's so important. Some of those kind of oldie but goodie drugs that have been around for decades, they're used now as frontline treatment off label, or at least it was off label because the label was old. So to think that they're methodically kind of going through and trying to review the literature and ensure that the way it's being used is also reflected on the label, that only, again, provides that reassurance to patients that I'm getting a drug that's right for me. And then, of course, in some of the drugs, I'm sure it relays its usefulness to prior authorizations and approvals and things like that. So I think that's a really interesting development that is very welcome to make sure that the information we have and can share with our patients as well as our nursing colleagues is current and up to date based on evidence, as she said. So it's very obvious that this progress in drug development and approval has created great impact, not only, of course, to patients, but certainly to clinicians and our nurses. What are the main ways that you're seeing this rapid pace of drug approval impact nursing practice?
I think first and foremost, when I talk to nurses, these approvals are so fast paced. It's just really difficult. And you mentioned this earlier. It's difficult to keep up with all of it. Yet it's incumbent on us as nurses to stay informed about these newly approved drugs or new indications in drugs, because we're the front line in helping these patients manage adverse events. Many of these drugs are designed so patients have to stay on them for extended periods of time, or at least they get the greatest benefit by staying on extended periods of time. So our patient education is key in helping patients do that. I think how often we hand these oral targeted agents out to our patients and then they go home with them. How much are we following up? How much are we following up on the drug-drug or drug-food interactions? Are they taking it on an empty stomach or with meals as directed? Are they taking it the way they are supposed to be taking it? All of this affects how effective that drug will be for that patient, or it could affect how serious their side effects get. So our role in making sure our patients and their caregivers are truly educated about managing these, looking for and reporting and managing these adverse events are just more and more important the more drugs we have available for them.
And I think based on how you described that we're seeing so many more tumor agnostic drugs, or we're seeing new indications for drugs that have historically been approved for one histology, and now it's kind of because of the biomarkers that it's targeting, it's shifting to others. I think that provides us as nurses an opportunity to work with our colleagues who maybe, if we are in maybe a more subspecialized program treating only certain diagnoses, going to our colleagues who treat something else that we don't, but they've used this drug before, working with our colleagues and our teammates to see what was your experience, how did your patients respond, and using each other to kind of teach each other new things as those therapies continue to develop and become more widespread. I think that's one unique feature of these new indications that are coming through.
I agree. Collaboration, interprofessional collaboration, all that is very important for all of us to stay updated as we should.
So now that we're in 2023, let's look ahead a little bit. What are some of the current and future trends that we see in pharmacologic cancer treatments? What's on the horizon? What should oncology nurses know or anticipate coming down the pike in 2023?
I think we will continue to see, of course, many new drugs that are approved. We will see new indications. I think particularly we'll continue to see cellular therapy agents developed. We'll see them gain new indications. I would be willing to forecast that we're going to see more and more of the bispecific immunomodulatory drugs or those antibody drug conjugates, all of those drugs that kind of are designed to treat the cancer in a couple of different ways, to onslaught what you're trying to do to that cancer by not just targeting the tumor, but targeting that immune system. And in fact, I think harnessing the immune system itself is going to continue to be a mainstay of new developments, as well as seeing new pathways discovered and new agents targeting new biomarkers that we will need to learn in 2023. What are those pathways? How does that drug work in that particular pathway? I also believe that we'll see additional biosimilar agents approved for cancer treatment. And we will see for our monoclonal antibodies, we're seeing that they're beginning to do more and create more and more subcutaneous formulations of the monoclonal antibodies. And that's really a wonderful thing for our patients. That means less time they have to come into our centers and spend with us, getting those long infusions so that they can come in and not have to spend as much time in the chairs in the infusion room, but be able to come in and get some of these same monoclonal antibodies just in a shorter time interval by a subcutaneous formulation.
And we've mentioned a few times already on this episode of just the challenge of keeping up with not only awareness, but understanding of new drugs that are being approved. Do you have any tips to help oncology nurses as they continue to learn and stay up to date on these cancer therapies?
I swear by the FDA website myself. You can sign up for email notifications for drug approvals. You can either get notified by email for every drug approval they make, either new or a new indication. They will let you know those. That helps me stay updated. Or you can get a weekly summary of those if you're not quite as into it as I might be, which I totally understand that. There also is the FDA website. They have a list. If you just want to go in and look at their list, that lists all of the new drug approvals. They do the same thing for biosimilars. There's a site devoted just to biosimilars. I am going to have all of these show up on the episode information. Jaime will be able to put all of these websites on there should you want to go and take a look at that. I think a new discovery to myself and to Jaime was something called the Drug Information Soundcast in Clinical Oncology. I just took a look at this today, tipped off by Jaime, and this is something called DISCO is the acronym for this. How can you not love anything named DISCO? These are 5-minute or less podcasts that highlight new approvals. So in 5 minutes or less, you can click on and get the information, really succinct information about a new drug that got approved. So very kind of cool ways to learn about these new approvals. That website we will also place on our episode information.
Those are great ideas. I am on the listserv, the FDA email listserv as well. And I think there's different approaches to it. Sometimes I can't really learn about something until I'm preparing to actually use it or work with my patients on it. But even just having awareness, name awareness or approval awareness to say, oh yeah, I do remember seeing that drug name come through my email. Let me fish it out of my inbox, or let me go to that website and review what they released. Even just keeping the name in the back of your mind until you're ready to learn more about it can be helpful as well, versus it kind of showing up all of a sudden and be caught off guard. So I think that there are some strategies, and we'll give some great resources of things that you can add to your toolbox just to kind of stay as informed as you can be and take things kind of as they come.
We live in the age of the internet. So just type in the name. You can usually type in anything close to the name. And in 2 clicks, you can get to that drug information. So I use that method a lot to get new information about these drugs.
Absolutely. And certainly the industry branded websites have lots of great information on there too. You just have to always evaluate those with the right lens to be sure that you're acknowledging they're also trying to sell a product on some level, but they still have great information that is thorough and usually well produced. And so certainly worth checking out if it's still a branded product, looking at the actual manufacturer's website for any tools. They sometimes will have education tools for nurses and patients alike. So certainly always consider that if it's a brand new drug that is still through an actual brand name. Well, Teresa, we've had a great conversation today. I still feel tired for you and having to pronounce all of those drug names. But as we wrap up, we like to always ask a few of our final questions just to summarize what we've talked about today. So to start things off, what are some common misconceptions about new drug approvals?
I think one of them is about accelerated approval and what that means. Sometimes the fear is, a drug gets moved through quicker and it gets approved, then nobody's going to look at that drug again. It's going to definitively stay on the market. I think that is a misconception. And just for all of our listeners to know, for those approvals, there's definitely more data to be collected and evaluated. I have read that CDER is even requesting that those confirmatory trials are started at the time of those approvals or very close to the time of those approvals. Those drugs, if the data is not verified, can be pulled off the market. And that first accelerated approval may or may not be the end of that story.
What's something about our topic today that's not often discussed, but you wish people knew more about?
I think a global perspective of these drugs. I think when they come at us individually, It's just so you used the term overwhelming earlier, and I agree with that. I think more nurses can learn about non-proprietary or generic naming of drugs and what those names try to convey to us. We began to put them in classes, kind of like we used to do with our cytotoxic chemo agents. We put them in our mind in classes of agents. And I think that is something that I hope nurses will continue to learn about, that these drugs are in classes and that there are similarities between many of the drugs that are approved.
I think that's a great comment. And, I think back to when I was a new oncology nurse and I approached it by trying to learn a single disease site. So breast or colon or lung, which at the time only had a handful of drugs. But that used to be kind of the way to approach it because there wasn't a huge, arsenal of things to use against a diagnosis. And now, as you've mentioned, you're better served by learning the drugs by classes because we know that they are now shifting from histology to histology based on biomarker driven therapy. So as you mentioned, it's just a sort of a paradigm shift in how we think about the drug approvals and how we kind of anticipate those side effects and that patient education that we'll have to provide.
Correct.
Speaking of that education, what additional training or education do you think oncology nurses need to understand these new anti-cancer agent approvals?
I encourage nurses to try to stay abreast of these new approvals. Trust me, our patients are staying abreast of these new approvals. So we have to do it too. When I think about these, and every time I do a new presentation, it reminds me that there are two areas that kind of underpin what we need to know about these agents. And those are the areas of genomics and immunology. And I think to clearly understand these new drugs, we have to at least have a basic knowledge of the immune system and genomics and genetics. I've been really proud of ONS in the past few years. There's been an advisory group that has created an ONS genomics taxonomy, encouraging all of us to begin to get fluent in the terms, biomarkers, to be very careful about using correct genomic terminology. They're not all mutations, and we don't need to label everything a mutation. There are many variations in these biomarkers, and I think that we all have to learn this together. This is not something we were taught in school. Even if you graduated recently, this genomics taxonomy can be the foundation for our terminology. And this is important to talk about in all of these agents. So I think genomics and immunology are two areas that will serve you well to delve into to get a foundation for all of these new drugs. And I looked through today the learning libraries that are on the ONS website. I will have 4 of these on here on your reference list, but there's one on oral medications, which many of these that are approved are orals. Biosimilars, there's one on immuno-oncology, and there's one on genomics. So these learning libraries actually are wonderful resources for all of us to find podcasts or articles or other methods of learning about these, because learning about genomics and immunology is going to give us that foundation to learn more about all of these drugs and understand them. And we have to understand them to enable us to teach our patients. If we don't understand it, we can't get the concept to them.
I completely agree. And I think your comments are spot on of really understanding the underpinnings of the mechanism of action. And that requires, immunology and genetics and genomics and just diving into that content that, as you said, most of us did not receive, especially if we went to nursing school more than 5 years ago.
Right.
So, I think that's just a whole, while yes, learning about the drug itself and how to teach your patients about expected side effects, that's the end point we're trying to get to, but to be able to do that effectively and I think really firmly grasp the mechanism of action, it does require taking a few steps back. And I've had to do that myself. And it's really interesting. And I think pretty gratifying once those dots all connect and you're like, I get it. But it does take some extra effort to make sure that you're connecting all those dots correctly. Similarly, what are some additional resources that patients or even providers that want to learn more about oncology pharmacology and new approvals, what are some resources that they could tap into?
We've mentioned several, but there is an additional one I want to mention, and that's called Project Live and Label. And that's not me just saying Livin. That is LIVIN apostrophe is what it's been named by the FDA. And it's a collaboration between the FDA Oncology Center of Excellence and the American Association for Cancer Research. This collaboration is supported by ONS and the Hematology Oncology Pharmacy Association, known as HOPA. So this is an educational initiative that aims to foster a broad understanding of the product labeling of these new products that are approved and really increase awareness of these product approvals in the cancer community. So it is using those product labels as kind of a roadmap. These episodes have discussions between an FDA reviewer, clinical trial investigator, a patient, and the actual drug company on the backstory of this development and the FDA review process. We're hoping that future episodes will include oncology nurses and pharmacists in the discussions as well. But the audience is all of us. The audience is physicians, nurses, other healthcare providers, cancer patients themselves, their advocates, their families, the industry, any of us who wants to seek a better understanding of all of these cancer therapy developments. So along with DISCO, I think this is just a really unique approach by the FDA to bring this information to us in a format that we can understand.
Well, Teresa, as I said before, thank you so much for all of the wealth of information you've brought to us, your expertise, your experience in saying all of these difficult drug names and helping us to understand the classes that they come from and kind of how things will be changing in the future. So I always enjoy talking to you and always learn something new. As we end our episode today, do you have any final comments for our listeners?
I just thank you, Jaime and ONS, for the chance to do this podcast. I thank every one of you who have taken your time to listen. I appreciate that. I really believe that we as nurses are really integral to educating our patients about these newly approved treatment agents. We want our patients to know what their treatment options are, and we want to educate them to help stand these drugs as long as they are effective and conducive to their quality of life. We want our patients more than anything to have the full benefits of these new and novel treatments. So thank you all for being interested enough to take your time to listen to this podcast.
Thank you so much for your time with us today, Teresa. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.